Hello, my name is Lakisa Walker. I'm in Professor Hoffman's medical terminology class. I am doing a case study on a 41-year-old African American lady that had a hysterectomy 10 and a half years ago, and she started having vaginal bleeding over a year. Um, the procedure was trachelectomy, excuse me if I can't pronounce this right, trachelectomy procedure, and that means that it was a removal of a nub of the cervix that was causing the bleeding. That was the assumption. The 40-year-old black female who had a total abdominal hysterectomy approximately 10 years ago, and within the past year, she was having regular episodes of vaginal bleeding. This was associated with cramping and all the above, all the symptoms that some females have. The patient had been examined in the office while bleeding, and it appears that she had a cervical stump at the back of her vagina that was causing her to bleed. Mainly, the concern was where was the blood coming from after the 10-year hysterectomy. There shouldn't have been no blood at all being seen. So, in this case, they had considered not to do an intracervical intercervical sample in the office because there was just a nub of cervix with no cervix OS visualized. The description where the procedure took place, the patient was taken to the operating room, placed on a table, vital signs were stable, general anesthesia was admitted. She was placed at a dorsal lithotomy position, prepared and draped in the usual sterile fashion. Speculum was placed in the vagina, and the cervical stump was grasped with a single tooth teneculum. A Foley catheter was placed. Next, a sublingual incision was made. A versus needle inserted, and a pneumonia peritoneum obtained. A 10.5 trocar was then placed. The Vinci camera was placed. Intra-abdominal cavity identified. There was noted to be extensive ahesions with bowel adhesion. There was also, once again, a lot of abdominal adhesion, which made a lot of scar tissue due to the hysterectomy 10.5 years ago. When they made 3 more trocar sites, 2 lateral 8mm ports, and a left upper quadrant 5mm port. On the left side, they placed a bipolar grasping forceps. On the right side, monopolar scissors were administered. The Da Vinci robot was docked, and at the point, extensive lysis of adhesion was performed mainly with the bowel that was adhesed to the anterior abdominal wall. And eventually they were able to make their way down into the cul-de-sac, where there was further adhesion bowels to the posterior vaginal. They were able to push on the teneculum that was on the cervical stump, and then they were able to proceed with the monopolar scissors and bipolar forceps using sharp and blunt dissects the bladder off the vaginal cuff. At this point, with the pressure being placed on the teneculum that was attached to the cervical stump, the monopolar scissors were used to just excision the cervical stump at the vaginal apex. And this was just removed through the vagina. The hole in the back of the vagina was then closed with an O-V-lock suture, starting at the right side running to the left and then back to the right. This was fairly small, a very small incision. Took about 2 or 3 sutures to get all the hematosis across. Um, we elected not to continue with the lysis of adhesion as the patient is in pretty aseptic, and we did not want to risk any bowel injury, and therefore the procedure was terminated at this point. The instruments were removed, the new peritoneum allowed to resolve, and the incision closed. The umbilical incision was closed with 0 vitral on the fascia, and the 4 through 0 vicial used on the skin of all the incisions was completed. Patient's Foley catheter was removed, and the procedure was ended. She is awake and taken to the recovery room in a good condition following the procedure. Once again, this procedure was done on myself on April 30th, 2015. My conclusion was I was very, very, very just out there, not knowing where the bleeding was coming from. I was told, once again, me getting a hysterectomy 10.5 years ago, that I should not have any bleeding, and boom, it pops up that I'm bleeding for over a year. Once again, my conclusion is kind of a mystery in a sense, because I start bleeding again after the procedure 2 weeks ago. So I'm just kind of like in a maze, and I'm hoping that Professor Hoffman, you can help me out to investigate why am I still bleeding. They did take my, I guess the skin that they took out, or the nub of the cervix, to histology to see if it was cervical, and thank God it was not cervical. So I'm hoping I did the terminology better than what I think I did. Sometimes terminology can be a little difficult, but once again, this was my case study, and I wanted to present that to Professor Hoffman so you can kind of help me out a little bit and let me know exactly what I need to do. Thank you so much for your time, Professor Hoffman, and hopefully I was successful with this case study. There's always a first time for everything, so I appreciate your time. Thank you so much. You have a good night. Goodbye, Professor Hoffman.